Okay. So let's move on to the valvular congenital heart disease endocarditis one. Yeah. Right. And we start with a question on aortic stenosis. Right. Now, before we go to this MCQ, aortic stenosis is a very common problem. It's a very common problem. Now, in Sri Lanka, we see quite a lot of chronic rheumatic valvular heart disease. See quite a lot of it. But in the West, the commonest valvular problem is actually aortic stenosis. Right? Because remember, aortic stenosis has a very similar pathogenesis to atherosclerotic coronary disease and atherosclerotic vascular disease. Right? There's a very similar pathogenesis, very similar risk factors as well. I'm not going to go into details, but remember that. Right? And there's a very strong correlation between aortic stenosis, aortic calcification, and coronary artery disease. Very close relationship. And even in Sri Lanka, I'm sure in the next decade or so, we will see an increasing incidence of aortic stenosis, right? Because we don't see much acute rheumatic fever anymore. It's mostly going to, so in a little while, we'll see this increasing. Right, so let's go back to the MCQ. So the first statement is right. Calcific aortic stenosis is associated with coronary atherosclerosis. Is absolutely right. Then aortic stenosis presents with symptoms, right? And of these symptoms, syncope is an important presentation. And in the SCQ, I have asked one of the SCQs, I've asked the cause or etiology or pathogenesis for syncope. Have a look at that and answer that. So syncope, what are the other presentations? They can present with heart failure symptoms, right? And that indicates very, very bad disease, right? Significant problem if that's the case. And also they present with angina, right? Why do they present with angina, Lamai? Simply because what happens is the patients have progressive left ventricular hypertrophy. The muscle mass increases, right? When the muscle mass increases, there is loss of supply, right? It's inadequate supply. So the heart muscle, this hypertrophic heart muscle is ischemic, giving rise to angina. Another reason is, I told you that aortic stenosis is associated with coronary artery disease, right? And that again can cause angina. So that can cause angina apart from the high muscle mass can also cause angina because the supply is lower, right? There is poor supply. So these are the causes for angina, right? Okay. Now, number 3, we've talked about this, the physical signs of aortic stenosis, right? The typical sort of low volume, slow rising carotid pulse. Now, what are the treatment options available for aortic stenosis? The first thing you have to know is we do something called a echocardiographic classification of severe aortic stenosis. That's the first thing we do. So we look for evidence of severe aortic stenosis. Then මේවා මතක තියාගත්ත අත්‍යවශ්‍ය නැහැ, but better if you remember it. Sorry? Oops, sorry. So severe aortic stenosis is determined on the velocity of the aortic stenosis jet velocity, right? And also the pressure difference across the aortic valve, the pressure difference. So the usual cutoff we take, mean cutoff we take is 40 millimeters mercury. And you say it's very severe when it's more than 60. Very severe when it's more than 60, but severe when it's more than 40. Also, the valve surface area is less than 1 square centimeter, right? Valve surface area is less than 1 square centimeter. ඕකෙන් අර pressure gradient එක චුට්ටක් මතක තියාගන්න in for an MCQ that might be useful. So more than 40 pressure difference across the aortic valve. And if it's more than 6, it's very severe. Right. So this is your definition of severe aortic stenosis. This is your definition of severe aortic stenosis. And also very severe කියලාත් එකක් තියෙනවා. Now, there are other entities of severe aortic stenosis also, which I am not going to go into. Those are postgraduate. But for an undergraduate, මේක මතක තියාගත්තා නම් තව තියෙනවා okay. Low gradient කියලා එකක් තියෙනවා. Low flow, low gradient කියලා ඒව ඔයගොල්ලන්ට වැඩක් නෑ එච්චර. Right? Those are too much for you. Right? Right. Okay. Summary is that if you have severe symptomatic aortic stenosis, you need intervention. Right? There is no doubt about it. If you have severe symptomatic aortic stenosis, you need intervention. No doubt. Right. So, Ari, that is the first thing you remember, number one. Number two thing you remember is if you have asymptomatic severe aortic stenosis. So, severe symptomatic intervention, no doubt. If you have severe aortic stenosis, but the patient is asymptomatic, you do intervention if they have an ejection fraction of less than 40, right? Less than 50, sorry. Ejection fraction less than 50, right? They are going to undergo other cardiac surgery. Best response MCQ, right? Or they have a positive exercise stress test. Now make a සාමාන්‍යයෙන් මේක ලංකාවේ වැඩි කරන්නේ නැහැ මොකද මේක ටිකක් ලෙඩක් right because there is a risk of undergoing patients to with aortic stenosis stress test ඒක කරන විශේෂ විදියක් තියෙනවා don't worry about that but for your purposes remember asymptomatic aortic stenosis you do if the ejection fraction is less than 50 or the patient is undergoing some other cardiac surgery. Also, there is other recent evidence that says that there are certain other echocardiographic parameters that might also indicate intervention. So, for your purposes, undergraduate final exam. Number one, you intervene in aortic stenosis if they have symptomatic severe aortic stenosis, no doubt. And severity classification කොටසක් මම කිව්වා. Number two, you also intervene if they have asymptomatic severe aortic stenosis, if the ejection fraction is less than 50 or they are undergoing cardiac surgery, right, for something else. Right. LV dysfunction is an absolute contraindication to aortic valve is wrong, right? Take a baradi, that is completely wrong. Balloon valvotomy is a treatment of choice. So remember, we do not do balloon valvotomy in aortic stenosis, right? The two ways are you either replace the aortic valve open surgery or you do something called TAVI. In patients who cannot undergo open heart surgery, we do TAVI. TAVI කියන්නේ මෙන්න මේක. It's a minimally invasive technique where you sort of do a transcutaneous aortic valve implantation. මෙන්න මේ වගේ තමයි ඔක කරන්නේ. catheter එකක් දාලා aortic valve එක replace කරනවා. Right, like that. It's called TAVI. Right, and this is very useful for people who can't undergo major cardiac surgery. This is very useful, very useful. Right. Any questions about aortic stenosis?
Sir, if they are symptomatic but don't meet the severity criteria, do you intervene?
No. Godak patients, when they are symptomatic, they will have severe. Yes, most of them. Right? It's an exception that they don't. If they are symptomatic, they will almost always have severe disease. Yeah?
Okay, sir, got it.
You need an expert opinion for that sort of thing. Because you have to say, the symptoms could be due to something else. So you get syncope, heart failure, and so you have to look for other causes and you have to be very careful. So that's a different story. Yeah. Right. Okay, good. Right. So let's go to mitral.
Sir, excuse me.
Oh,
sir, after this balloon surgery, does it work like a normal valve or will there be a regurgitation?
ගොඩක් වෙලා regurgitation පොඩි එකක් එන්න පුළුවන්, but this is very successful. ඔක දාම සාමාන්‍ය වැඩ කරනවා. හරි? But you can get a little bit of regurgitation depending on the operator. හරි?
Okay.
Okay. Right. Now this MCQ is on mitral stenosis. As you know, the commonest cause of mitral stenosis is rheumatic valvular heart disease. There is no doubt about that. So කාටවත් ඒක වරද්ද ගන්න බෑ MCQ statement එක. That is absolutely true. Hurry. Can present with hoarseness of the voice. That is a bit of a funny one, but I will show you. Right. Now, I'm sure this X-ray might be familiar. I think I've shown this to you during an OSCE class. So here you see that in mitral stenosis, there is left atrial enlargement. How you see that on the X-ray is a straight left heart border. So when there is left atrial enlargement, you see a straight left heart border. Usually the heart border is like that. This is now a straight left heart border. Another thing is the left atrium sits right there. So, and this is where the bronchi sort of bifurcates. So bifurcates. So the left atrium enlarges, the bronchi are pushed to the side. Pushed to the side. There is another thing where in this small space, you can see this aorta here. This is the left atrium, bronchi. Space here, this is the recurrent laryngeal nerve. Alright? Because it goes under the aortic arch. This is the aorta. Alright? This is the left atrium, bronchi, recurrent laryngeal nerve. So, as an unusual consequence of mitral stenosis, which causes left atrial enlargement, it gives rise to hoarseness of the voice, right? Because it presses on the recurrent laryngeal nerve, right? It's called Ortner's syndrome. Ortner's syndrome. Sometimes, make an additional point, the left atrium becomes so big that it presses on the esophagus posteriorly and can cause dysphagia. There is a name for that. Surgery dysphagia lusoria. And it MCQ. So mitral stenosis gives some size. Okay, if it's a massive left atrium, it can give rise to dysphagia as well and hoarseness of the voice because of the compression of the recurrent laryngeal nerve. So this is just anatomy, but take a product clinically related to mitral stenosis. Any questions about that? Now, I told you during your clinical appointments that mitral stenosis causes a rumbling, low-pitched mid-diastolic murmur, right? And a loudest one. So the murmur is what you get. Here, rumbling, low-pitched mid-diastolic murmur, and the S1. Then you get the S2,